We're going to move on to the back, axilla and lung portion of the exam. But before we do the steps of that exam segment, let me talk about a couple of important generalities. The first one involves draping. Throughout the exam, you're going to need to adjust the gown and sheet to provide maximum visibility of the segment of the body that you're examining. And this is a very important thing for you to practice during your individual session so that you get used to changing the drape appropriately. This is going to require some exposure of the patient with these drape changes, but that is something that, if you need to do that in order to do your exam adequately, that's something that you have to just accomplish. The second thing that I want to talk about is that this part of the exam brings into focus a certain principle of order of the steps. The order of the steps of the exam usually occur in the same sequence. Inspection steps come before palpation steps, which come before percussion steps, which come before auscultation steps. There is one portion of the exam where this is not true, and that is the abdominal exam. And in that particular portion of the exam, you do your auscultation before your palpation. And the reasons for that will be discussed when we get to that segment of the exam. But for your own memorization aid, remember that usually inspection comes before palpation, followed by percussion, followed by auscultation. And we will certainly demonstrate that in this particular exam. The next thing I want to talk about is that you're going to begin to practice something that may be a little frustrating for you, and that is your percussion technique. I'll demonstrate this for you more specifically when we're going through the steps of the exam, but in the back and lung exam, and then later in the cardiac and abdominal exams, you will use the technique of percussion, and this is something that requires a fair amount of practice in order to become accomplished at it, and we'll go through that as well. So now we're going to start with the exam itself. Normally this exam takes place with the patient seated as you see them, and you're doing the examination from the right side of the patient, as we do everything that can be done from the right side. But in order for you to be able to visualize what we're doing, we're going to turn the patient on the exam table so that we can clearly see his back. Okay, we're ready to start the posterior thorax and back exam. I'm standing to the right of the patient, just as I would be if the patient was sitting normally as they do on the table. And remember that you won't be doing the exam from this position. I'm doing that so that you can see what I'm doing. The first thing we're going to do is ask our patient to take their arms out of their sleeves on both sides. And you can see that this provides complete exposure of the posterior thorax and back of the head and neck. And that's exactly what you need before you do any exam segment, is to get good exposure of the area that you're trying to examine. We start with an inspection step. We look at the alignment of the shoulders, the musculature. Obviously we can see the skin. And we do that inspection step first. Next we move to palpation steps, and we start by palpating the spinous processes. You're going to do that from the cervical spine all the way down to the sacrum. When you're doing the cervical spine palpation, you want to support the patient's forehead with your other hand and then press on the spinous processes and ask your patient to tell you if this elicits any pain. So you tell me if this is uncomfortable. Okay? The next step is to do a light pounding. It's a percussion step, technically. And again, when you pound on the cervical spine, you want to support the patient's head. And then you can release once you get to the thoracic and lumbosacral spine. This is followed by percussion of the costovertebral angles, there and there. This is done to elicit potential kidney tenderness. So you've done your inspection, percussion, palpation, and then some percussion. Now we're going to do the percussion of the lung fields. The first thing you have to start to practice with is the use of your fingers to do the actual percussion technique. I'm just going to randomly pick a spot here and show you that you have laid your non-dominant hand down on the surface you're percussing. You're aiming for the distal interphalangeal joint of your middle finger, and you're going to be tapping on it with the tip of your middle finger of your dominant hand. So you can hear the sound that that generates. You want to have the other fingers of your non-dominant hand up off the surface that you're percussing, because if they're down on the surface, they will damp the vibrations. So you want to press that non-dominant hand third finger down on the surface you're percussing. You want to use a wrist, primarily wrist-only movement, and then at right angles ideally, strike. And you're going to get variations of sound depending on how well you do your technique. This will improve with time. We're going to want to percuss the lung fields, the posterior lung fields, and an important thing for you to do is to think of a logical sequence of percussion. We suggest one for you in your manual, and that is to percuss paravertebral, mid-scapular, posterior axillary, and then mid-axillary. And you have to sort of imagine these lines in your head as you're doing your percussion. You also want to get in the habit of imagining the underlying anatomy while you're doing any part of your exam. So you want to be visualizing the projection of the lungs onto the surface of the posterior thorax so that you can think about when you're percussing upper lung, middle lobe on the right, lower lobes on the right and left. The other thing that we want you to do, and you can do it either with the posterior exam or the anterior exam, is percuss the apices. And you can't see these now, but these are right overlying the supraclavicular areas, and you can put your finger there and percuss. The other thing I want to talk about is the 2-point comparison rule. You never percuss more than 2 locations at a time without comparing it to the opposite side. The whole idea of this is that you want to hear symmetry in your percussion so that you can assess for yourself that the lungs are similar on both sides. You're basically using the patient's lungs from one side to the other as their own control. So that if you hear dullness on one side where you hear resonance on the other, that isn't what you expect, and so that's something that's going to make you think that there may be underlying pathology. So you always do 2 points on one side, followed by 2 corresponding points on the other side of the vertebral line, something like this. So you can see I did paravertebral, mid-scapular, posterior axillary, and mid-axillary lines. And I always did 2 on one side and then went to the other side to compare the similar area. Let's do that one more time. You can perhaps hear that there was some tone change when I got to the bottom of the lung and got to the point where we were below the diaphragm, and that's where you have a tone change from resonant to dull, for example. When you've got underlying air, you've got a resonant tone. Underlying soft tissue, you've got a dull tone. And you may or may not have heard that as I was doing that. But that would be a logical sequence for percussion of the posterior thorax. And you've included the mid-axillary region. If for some reason you can't do the mid-axillary region now, you can do it later when we percuss the anterior thorax. One other optional step that can be done that involves percussion of the posterior thorax is something that we call diaphragmatic excursion. What this is done for is to assess the distance that the diaphragm moves between complete expiration and complete inspiration. What you're looking for is not so much the absolute value of that distance, but whether or not the sides are, again, comparable. Because if one side shows that the diaphragm moves only a very small amount, 1 or 2 centimeters, and the other side shows that it moves 6 or 8, you can be alerted to the fact that there may be underlying pathology. Those measurements should be even. Let me demonstrate how you do that. First of all, you need to have your patient cooperate by listening to your instructions for breathing and by holding their breath. The first thing that I'm going to ask you to do is to take a breath in and then breathe it all the way out and hold it. Don't do it yet. You'll have your patient take in a deep breath, breathe all the way out, and hold it. This is going to make the diaphragm rise maximally in the chest wall. While your patient is holding their breath, it's best for you to hold your breath too, because then while you're doing your percussion, you can also get a sense of how uncomfortable your patient is. And if you feel like you need to take a break, your patient can be told that they can take a break as well. While the patient is holding their breath out in full expiration, you will percuss down from the top of the chest until you hear a change from resonance to dullness. And then you will mark that with your pen on the patient's back. You'll then have the patient take a few breaths to get to feel more comfortable, and then to take a deep breath in, taking the diaphragm to its maximal low point. Repeat the percussion until you hear a change, and perhaps we'll be able to hear a change on the tape, and then mark that as well. That's repeated on the other side, and those distances between the 2 points are compared. So let's try that. Okay, patient, can you take some breaths easy and then take a big deep breath in, blow it all the way out and hold it. Okay, you can breathe. You may or may not have heard that change, but that's about where I hear it. And I'm doing this measurement, roughly in the mid-scapular line, somewhere between the paravertebral and mid-scapular line. Okay, can you take a deep breath in and hold it? Good, you can breathe. And I'm going to mark that again. So you see, we've got a pretty good diaphragmatic excursion there. I held my breath while the patient held their breath so that I knew if and when the patient was getting uncomfortable. And realize that once you've marked this upper border of diaphragmatic mobility, you don't need to start your percussion up here again for the lower border. You can start somewhere close to that. One of the secrets to keep in mind, though, is that in order for you to be able to hear a difference, you want to start high enough so that you hear resonance for a while before that note becomes dull. And so if you start very close to the point where that changes, you may not be able to hear the difference. Let's try that again on the other side. Can you breathe in and then breathe out completely and hold it? Okay, you can breathe. I'm marking it right there. You okay?
Good.
Now let's take a deep breath in and hold it. Okay, you can breathe. And I can too. Gosh, am I hurting you?
No.
Good, okay. So there we go. I don't know how well you heard that, but we have virtually similar excursions from one side to the other. And that is the technique of doing diaphragmatic excursion. This is an optional step in your exam, but it's a step that, when you have a patient who may have some pathology underneath the diaphragm or directly over the diaphragm, you really want to know how to do this skill, and so you may well want to practice that even though you won't have to demonstrate it in the exam. That completes the percussion portion of the exam. Now we move on to auscultation. This obviously uses your stethoscope. One thing I want to emphasize greatly and that we're going to be big sticklers about is that you listen to inspiration and expiration throughout their lengths when you're auscultating the lungs. You are learning about the difference between bronchial and vesicular breath sounds, and the only way to figure out whether you're hearing bronchial and vesicular breath sounds is to listen throughout inspiration and throughout expiration. You'll see clinicians taking shortcuts all the time and lifting their stethoscopes off the chest too early or too late, but we want you to practice listening carefully throughout inspiration and expiration. You're going to basically cover the same areas that you covered with percussion. The apices, paravertebral, mid-scapular, posterior axillary, and mid-axillary. And you're going to use the two-position comparison rule so that you listen in two spots, move to the corresponding spots on the other side, listening for symmetry from side to side. You need to give your patient good directions because they need to accentuate their breathing a little bit. So you want your patient to breathe in and out at their normal rate with their mouth open, and then to obviously ask for a break if they feel like they're getting uncomfortable. You're basically hyperventilating your patient. So they may feel a little dizzy at some point, depending on how long you take, and they may need a break, and you need to let them know that they have permission to ask for that. So a little deeper than normal at your own rate with your mouth open. And some patients really need you to show them, so you can show them so that they're making some noise with their mouth. All right, are you ready? We'll start. You want to do this with the diaphragm, so you want to tap and make sure that you've got the diaphragm position on your stethoscope. For many patients, when you do the apices, the diaphragm won't fit in their apices, so you do need to switch to the bell, the smaller diameter to fit into the apices. You will be doing this from the right side of the patient and holding the head of the stethoscope in your left hand as you see me doing. So let's go ahead, patient, and have those breaths start. Couple more. Good. You okay? Okay. You can see that your stethoscope head sort of covers a bigger distance than your percussion technique does, so that you probably will do fewer locations when you're auscultating. You also can see that you want to move quickly from location to location after full inspiration and expiration so that it doesn't take as long for the patient and you do an efficient exam. Okay. That completes the back and posterior lung exam, and we're going to move on to the axillary exam. This is basically a lymph node exam. So you're going to be covering the anatomical areas where lymph nodes exist. Again, you may not find anything, and actually that's what you're hoping, but you're covering the anatomical locations where a lymph node might be enlarged. You aren't going to see this well at all when I do this side, but I will do this side just to sort of introduce the technique, and then when I move to the other side, you'll be able to see the areas that I'm covering. You're going to cover the central lymph nodes, the anterior lymph nodes that are tucked up under the pectoralis muscle. You're going to do the posterior lymph nodes that are tucked under the trapezius, and then you're going to do lateral lymph nodes that are located under the arm and below on the humerus. So we cover each of those areas as high as we can into the axilla. After you do this axillary exam, you're going to want to wash your hands. People expect you to wash your hands afterwards because you're going to continue on with other parts of the exam. So you don't need to apologize for doing that, and I think patients expect it. So after I do this axillary exam, I've got some towelettes that I'm going to use. You would go to the sink and wash your hands well with soap and water. Okay. Again, we're going to start central, then do posterior fold nodes, followed by anterior fold, and then lateral. To do the central, we use our skin-moving strokes. I'm just going to do this quickly. If your patient is ticklish, then you want to press harder, not softer. Are you ticklish? Okay. And you're actually at the top going to lift up that arm and feel down. Then you're going to hook your hands under the trapezius. Then you're going to use your other hand to get in front and then use it to go down the length of the arm. Now I'm going to come around to this side, and hopefully you'll see that a lot better. Again, here's how the patient needs to be positioned. You do want their arm to be relaxed. You will start with just have the patient move their arm out a little bit and start at approximately nipple level with circular strokes right up into the center of the axilla. When you reach that apex, you're going to lift up the arm to try and feel as high as possible. And then you will hook these fingers behind the muscle into that posterior fold and feel for any nodes that might be there. You'll then switch hands, use this hand to get into that anterior fold, stabilize it with your other hand, and feel for any lymph nodes there. Followed lastly by moving down the underside of the upper arm for the lateral nodes. Should we do that one more time? We want you to start by doing the central nodes, get as high up in the axilla as you can, and then actually lift the arm up a little bit. Then hook your hand behind the skin fold and feel for any nodes that might be there. Switch hands to get into the anterior fold and stabilize with your other hand, and then move down the arm. And then you're done with that portion of the exam. This will be followed by washing your hands and moving on to the anterior chest. In order to move to the next part of the exam, which is the examination of the anterior thorax, you have to change the position of your patient. You want the patient to lay down with their head at 30 degrees. So in order to do that, you've got to raise the head of the bed. Go ahead and let your patient lay down and give them something to put their feet up on. Hope your equipment doesn't fall apart. There we go. You want to remember to put the patient's feet up. It's very uncomfortable for a patient to lay back and have their feet dangling, so try not to forget that. Get your patient comfortable on the pillow. You can lay your head back on the pillow and their hands at their sides, and then you're actually going to untie the gown and lower it to approximately waist level, and you've got good exposure now of the anterior thorax. We're going to start, as we always do, with inspection of the anterior thorax and take a look at the skin, musculature, looking for symmetry or anything that's an obvious abnormality. Moving to the palpation step, you're going to palpate for infraclavicular lymph nodes. You're going to do that with your skin-moving circles simultaneously right under the clavicle. You're then going to press on the sternum, looking for sternal tenderness. And then press on the costochondral junctions, again, looking for any elicitable tenderness. Remember that the costochondral junctions flare out from the sternum. They're not next to the sternum all the way along. So again, you're going to be following in the line of where the costochondral junctions are. After that palpation step, you'll go on to your percussion of the anterior thorax. The same principles as we used on the posterior thorax are extant. You're going to want a logical sequence. We suggest parasternal lines, midclavicular lines, and then anterior axillary lines, remembering the two-position comparison rule. So let's do that. And then you're going to listen exactly in the same spots that you percussed, remembering that we're listening throughout inspiration and expiration. So you have to tell your patient to breathe again. Normal rate, mouth open, just a little bit deeper than usual. Go ahead and start anytime. Good. Remember that if for some reason you were not able to do the mid-axillary locations for either percussion or auscultation, you can do them with the patient in this position. That basically completes the examination of the anterior thorax.